you're gonna mess. Okay. Hello, our group is group 2 and we did fluids and electrolytes. This is Karen, Noelle, Julie, myself, and Irene. And we present you our patient, JG, 73-year-old male, admitted on August 30th for shortness of breath. Our patient is full code, no isolation required. Our patient has a couple allergies, CATs and diphenoxylate, which is an anti-diarrheal medication. The medical diagnosis for our patient was small cell lung carcinoma with intervals decreasing of intrathoracic lymph node and left-sided heart failure. Our patient has history of COPD with asthma overlap, OSA, which is obstructive sleep apnea on APAP, anxiety, depression, chronic kidney disease with shortness of breath present. Our patient is a fall risk. Vital signs were taken routinely, and our patient was also on a blood glucose monitor, as he is a type 2 diabetic. And so nutritionally, he was also on a carb control. Our patient has had an IV access peripherally on the left forearm, and the activity order was bed rest, as our patient is at BMAT level 2. Our patient could come to sitting position, but could not stand and be transferred independently. Our patient's vital signs were pretty normal. Temperature was 96.8, heart rate was 77, blood pressure 147/60, which is a little high, and a pulse ox of 97% on a 2-liter nasal cannula. Our patient weighed 297 pounds with a BMI stage 3 obesity of 40.27. Lab values showed hyponatremia, hyperkalemia, hypochloremia, and high levels of BUN and creatinine. And the glucose showed around 400 multiple times.
So for our general assessment, first for neurological, the patient was ANO ×4. The patient exhibited upper and lower extremity weakness. For cardiovascular, they had HFpEF, which is heart failure with preserved ejection fraction, and they also experienced an NSTEMI. As far as respiratory, they have small lung cell carcinoma, COPD, asthma, OSA, obstructive sleep apnea, and shortness of breath. For genitourinary, they have chronic kidney disease. And for eyes and nose, for the last shift, the inputs were 340 milliliters of blood, 20 milliliters of other products. Output was 1,650 milliliters of urine with a net total of negative 1,290. The patient exhibited hyperkalemia, hyperphosphatemia, hyperuricemia, hyponatremia, and hypochloremia, all having to do with their renal issues. As far as gastrointestinal, the patient exhibited a soft abdomen with normal auscultation, multiple loose BMs per shift, and their diet is on carb control right now due to the hyperglycemia, which also covers endocrine. As far as integumentary, they have a wound, an ulcer to the right calf, and another wound, which is ecchymosis on the sacrum, as well as edema grade 2. And then for musculoskeletal, they have a BMAT of 2, so the patient can come to sitting but cannot stand or transfer on their own, and they're also a very high fall risk. And then as far as psychosocial, the patient has anxiety, depression, inability to perform ADLs, and also loss of independence.
For level 1 assessments, our patient has shortness of breath, wheezing, crackles, chronic cough, chest pain with pressure, blood pressure reading of 147/60. Their SpO2 is 97% with a 2-liter nasal cannula. Without the cannula, it's 92%. The patient has hyperkalemia, hyperphosphatemia, hyperuricemia, hyponatremia, hypochloremia. The patient is fatigued. They have exercise intolerance, edema grade 2. They have an ulcer on their right calf and ecchymosis on their sacrum. They have anxiety and depression. For level 2 assessments, the patient has small cell lung carcinoma with interval decrease of intrathoracic lymph node, COPD, asthma, obstructive sleep apnea, NSTEMI, heart failure with preserved ejection fraction, chronic kidney disease, type 2 diabetes, with their weight of 297 and their BMI of 40.27. They are obese level 3 and overweight. For nursing diagnosis, physiological mode, the patient has fluid volume excess related to the chronic kidney disease as evidenced by their elevated BUN, creatine, and they're at risk for fluid overload. Electrolyte imbalances related to impaired renal function, ineffective breathing patterns related to their lung cancer, COPD, asthma, sleep apnea, as evidenced by the need for oxygen support, hyperglycemia related to impaired glucose metabolism and chronic kidney disease, as evidenced by their blood glucose levels being 401. The risk for falls related to them being on bed rest, decreased mobility, and electrolyte imbalance.
And then for self-concept mode, the patient has anxiety related to the patient's view of their current condition and their ability to get better, which impacts both their self-image and self-esteem. These are mainly caused by their cancer diagnosis, chronic kidney disease, and overall hospitalization. And then for role function mode, the patient has depression related to their inability to perform ADLs and their loss of independent living.
Some of the medications that were pertinent to our patient's diagnosis were insulin, which is a hormone. This would regulate the blood sugar levels and the body's energy supply, managing our patient's hyperglycemia. Albuterol, which is a bronchodilator. It would help our patient manage their COPD and asthma, increasing the flow of air through bronchial tubes. Furosemide, which is a loop diuretic, managing fluid retention and our patient's hyperkalemia, expelling fluids and electrolytes from the body. But to replace that, we would give our patient sodium chloride, being classified as minerals and electrolytes, correcting the hyponatremia and hypochloremia, maintaining fluid and electrolyte balance, and lorazepam, which is a benzodiazepine, managing our patient's anxiety. Additionally, we have amlodipine, which is a calcium channel blocker. This would treat our patient's high blood pressure. Allopurinol, which is a xanthine oxidase inhibitor, reducing uric acid production caused by the cancer medication or the chemo medication that our patient was on. Also, it's used to treat gout and kidney stones. Enoxaparin, which is an anticoagulant, preventing blood clots in patients, those who are especially bedridden, which our patient was BMAT2, usually staying in their bed for long periods of time. And citalopram, which is an antidepressant, increasing the levels of serotonin in the brain. And lastly, Ozempic, which is a semaglutide, also treating our patient's type 2 diabetes.
And then SMART goals for this patient. Short term, the patient will demonstrate improved fluid balance through reduced edema from grade 2 to grade 1 and stable vital signs by end of shift. The patient will demonstrate improved breathing patterns through proper positioning and appropriate medication by end of shift. The patient will have stabilized glucose levels within safe limits from 80 to 130 milligrams per deciliter pre-meal by end of shift. And then for long term, the patient will maintain serum electrolyte levels within normal range by discharge. The patient will report a decrease in anxiety and depressive symptoms by discharge, and the patient will remain free from falls until discharge.
As far as our nursing interventions, we have fluid and electrolyte balance. We will monitor our patient fluid status. So we will have strict INOs monitoring every 8 hours. We will have daily weights to assess for fluid retention. We would assess for signs of fluid overload. We would administer IV. We would administer hypertonic saline if hyponatremia is severe and per physician's order. We have frequent lab monitoring of sodium, potassium, BUN, creatine, and administer electrolyte replacement as per orders. We have hyperkalemia management. We will monitor cardiac functions with telemetry or frequent ECGs. We have potassium lowering meds as prescribed. For respiratory management, we have oxygen therapy. So we will continue oxygen therapy at 2 liters via nasal cannula. We will monitor oxygen saturation regularly to ensure it remains above 92%. For breathing exercise, we will encourage deep breathing exercise to promote lung expansion and spirometer. For glucose management, we will monitor blood glucose every 6 hours. We will administer insulin per sliding scale to control hyperglycemia. We have dietary education, so we will provide education on a carbohydrate controlled diet and CKD friendly nutrition for low sodium, low potassium. We have psychosocial support, so for anxiety management, we will encourage open discussions of feelings and fears related to diagnosis, mental health services for counseling. We have relaxation techniques, so we will teach relaxation techniques such as deep breathing, meditation, or guided imagery to help manage anxiety. And for fall, we would have bed alarms are in place, call light in reach, and we would assist with transfer, bed at lowest position, and clutter-free environment. For our evaluation, we have short term, so our patient would have demonstrated improved fluid balance through reduced edema from grade 2 to grade 1 and stable vital signs by EOS. The patient has demonstrated improved breathing patterns through proper positioning and appropriate medication by EOS. The patient has stabilized glucose levels with safe limits by EOS. Our patient has successfully expressed feelings of anxiety and depression, causing more concerns about their cancer, CKD, and hospitalization. And our patient has displayed affected adaptation of sickle. For long term, our patient will maintain serum electrolyte levels with normal range by discharge. The patient reported a decrease in anxiety and depressive symptoms by discharge. Our patient will express 2 to 3 positive affirmation about himself, and the patient will remain free from falls until just discharge. Thank you.
Thank you.
Thank you. We did it.
Yay! Ah.
Why am I sweating?
Me too.